Welcome everyone to the Office of Statewide Health Planning and Development, now HCI, OSHPA 3 Primary Care Clinic presentation brought to you by the Building Standards Unit, or BSU, within the Office of Statewide Health Planning and Development. You are here for the presentation for OSHPA 3 Primary Care Clinics, dealing with what is OSHPA 3, when to evaluate facilities, and how, what is the required documentation and expected timelines, and much, much more. If you haven't done so already, please feel free to download the handouts brought to you by and provided to you by in PDF format under the Go-To handout section of the Go-To panel on that dashboard. So if you go to your dashboard, there's a gray box labeled handouts. Feel free to click that little arrow, it'll expand, and you'll see the PDF documents available to you there. If you do have problems downloading those, no worries. Feel free to send us an email over to regsunit@oshpod.ca.gov. Again, that's regsunit@oshpod.ca.gov, and we would be happy to send those over to you if you have problems downloading those presentations. You will all be muted during the presentation. You will be here for about an hour and a half presentation with some question and answer sessions throughout the presentation, which will allow you to either raise your hand by clicking the little hand icon next to your name. We can go ahead and unmute you. You can unmute yourself to participate in an open mic discussion, or you have the option to type your question into the question section of the Go-To dashboard. Again, you can type your question in, or you can raise your hand to participate in an open mic discussion. Please remember that there is no silly question. We are always willing to help answer that question that who might help others as well. Again, if you do have a question after the presentation that you came to mind after we're gone, send an email to regsunit@oshpod.ca.gov, and we will be happy to send that answer over to your way. If you experience transmission difficulties, please feel free to log off and log back in using the same login information that the Go-To software sent you, and we will do the same if we experience transmission difficulties on our end. So for presenters today, we have Mr. Richard Tannehill. He is an architect and supervisor for the Building Standards Unit. We have Elle Grant with California Primary Care Association. We have Scott Peterson with Indy Architecture. And we have the rest of the Regs Unit team here at OSHPOD in the background answering questions as you type those into the presentation, into the question box. So Richard, if you're there, I'll go ahead and hand the presentation over to you.
All right, thank you, Caesar. Hello, everyone. This is Richard Tannehill with OSHPOD, or HCI now, and we'll go into that in a little bit. But this is a two-part series. This first part will be more of the nuts and bolts, and I'll kind of go over the agendas here in a second, but this is in cooperation with the California Primary Care Association, and there will be more information on that coming. We do know there is an issue right now with downloading the handout for the actual slide presentation, so bear with us on that. We'll either repost it or get it up to you later on, or email it out at another date. But right now we're trying to get that corrected. So we see a lot of comments saying that it doesn't open. So we are currently working on that. So with that, I'm going to move ahead here. As I mentioned, OSHPOD is now under a new name. We have went from an office to a department. We are now the Department of Healthcare Access and Information. So you'll hear the acronym of HCI, probably not during this presentation, but in other stuff. That is a change that we're currently going through, and you'll see some announcements coming over the next few months to that effect. So this presentation is for OSHPOD 3 primary care clinics, the what, when, and how. It's designed to help potential building clinic owners or people that run the facilities, architects, designers, engineers, contractors, or this part one, we're going into the what's of what is OSHPOD 3 and how is it applied. The when, as in when should you be evaluating your facilities, and the how to evaluate them. And this is where we're actually getting more into the nuts and the bolts of clinic spaces and the requirements. Part two, which will be on August 31st, it's going to be sponsored through CPCA, the California Primary Care Association, will be more of a workshop that we'll be doing, and Elle will discuss that a little more. But we'll just be discussing a lot of issues that clinic owners go through or should be aware of when operating or preparing to operate a clinic. So, excuse me, just real quick, this presentation will consider focus on the California Building Code architectural requirements, as well as we'll touch on accessibility toward the end. The application of OSHPD requirements. OSHPD is responsible for building standards development and enforcement, and we work with the California Department of Public Health for clinics licensure. We'll touch on that as we move through. And lastly, this will be based on the 2019 California Building Code, primarily Chapter 12, Section 1226, which is specifically for clinics. But as I mentioned earlier, we will also be touching on some accessibility in healthcare units. Again, I'm Richard Tannehill. I'm the supervisor of the Building Standards Unit. And with me today, we have Scott Peterson, principal with Indie Architecture, and Elle Grant, senior program coordinator with the California Primary Care Association. And with that, I'm going to pass this to Elle.
Good morning, everyone, and thank you, Richard. As Richard mentioned, my name is Elle Grant. I work for the California Primary Care Association. So I thought I would start by just introducing kind of who I am and who CPCA is. So we are the statewide leader designated by the Federal Bureau of Primary Healthcare as a state primary care association. So every state has a primary care association, and we are designated as the PCA for California. Our focus is to advocate for community clinics. So we help to lead and position community clinics, health centers, to improve the health status of their communities. So that's who CPCA is, and I work as the lead on licensing and provider enrollment for clinics. There we go, sorry. Still getting the hang of this. Oh, I need to go backwards, sorry about that. And so I've had the pleasure at CPCA of partnering with Richard and Scott during our work on the Community Clinics Advisory Committee, which is established in Health and Safety Code Section 1226B to help provide input for minimum facility standards for primary care clinics. The Clinics Advisory Committee was previously dormant, but we worked closely with OSHPD to convene the CAC. I think our first meeting was in February of 2020. And so we've nominated a list of community health center leaders and technical experts who represent health centers throughout California on the Clinics Advisory Committee. And we meet quarterly with OSHPD to identify and discuss building standards challenges that impact community health centers to better kind of streamline and align existing requirements with the operations and services that community health centers provide. So I also wanted to leave my contact information here. As I mentioned, I'm the lead on licensing and provider enrollment. So if you are not familiar with CPCA, or even if you are, but you have questions, concerns, or input on how we could better serve the community clinics throughout California, please feel free to reach out, or if there's any way I can assist you with your project, please do feel free to reach out. So jumping back into OSHPD 3, first we want to discuss the jurisdictions that are involved in licensing the clinic and the differences between the two. So we have the California Department of Public Health, and they are the licensing authority. They have their licensing and certifications branch, and they evaluate the licensing program and operations for clinics. They conduct the site surveys, and they issue the OSHPD 3 license. Now, OSHPD, they promulgate the building regulations. So as Richard mentions, we're going to be focusing today on the California Building Code because that is the piece that OSHPD focuses on. And upon request, OSHPD can also review construction drawings for OSHPD 3 certification if needed. I also want to point out the difference here between OSHPD 3 and OSHPD 1R. OSHPD 1R, as far as I know, is a little bit newer. So OSHPD 3 is what applies to primary care clinics, specialty clinics, psychology clinics, and the outpatient clinical services of a hospital. And OSHPD 1R, which I mentioned was a little bit newer, can be applied to non-conforming hospital buildings that have been removed from acute care service. And so in some situations, it may be helpful to look at buildings with OSHPD 1R. And Richard and Scott, feel free to chime in with more information if you'd like. So the OSHPD 1R buildings are still in the OSHPD jurisdiction, but since they were formerly part of the hospital buildings, some of the requirements are slightly different, and in some cases can be sort of an easier transition for the clinic.
Right, this is Richard. Just want to kind of expand on that a little bit. So what we've done with the 1R is make it so that the hospital can use those older buildings that are removed from acute care for several different types of uses. And it could be OSHPD 3, or it could be actually even clinics not under OSHPD 3. So today we're talking about OSHPD 3 clinics. We're focusing primarily on the primary care clinics, but you'll see a lot of mention about the surgery clinics, psychological clinics, et cetera, as we move through this. But we just want to let you know that 1R is a good alternative. And even if you're not with the hospital, they can lease out those spaces for other types of clinic uses.
Thank you so much for that, Richard. Okay, so moving in further into the what is OSHPD 3? So as we mentioned, OSHPD 3 applies to clinics that are licensed by the Department of Public Health. And so that includes clinics that are licensed under Section 1200 of the Health and Safety Code, which includes primary care clinics, specialty clinics, and psychology clinics. I'm waiting for the animation.
You hit the click the mouse. There you go.
Thanks, Richard. So, and it also applies to clinics licensed under Section 1250 of the Health and Safety Code, which includes hospitals providing outpatient clinical services in a freestanding building. So this is a list, a more detailed list of all types of clinics that OSHPD 3 applies to that fall under Sections 1200 and 1250. Okay, and so OSHPD 3 is under the building code section 1.10.3, and as mentioned, so it applies to licensed clinics and any freestanding building under a hospital license. OSHPD 3 is enforced by the local building department, so it's not enforced by OSHPD. So if you're reaching out to OSHPD for questions about the applications of OSHPD 3, they're a great resource. However, they are not the ones who are necessarily enforcing the regulations at the local level. You can find the applicable administrative standards of OSHPD 3 in section 1.10 in part 1, chapter 7, and part 2. And the building standards themselves are under the California Building Standards Code, and it's referred to as Title 24. And it also has amendments that are labeled as OSHPD 3. And those are included in the requirements. I'm having a delay with switching the slides. Okay, sorry about that. So there was a code application notice that was released to clarify the application of OSHPD 3. As I mentioned, the building standards are falling under what we call Title 24, and they apply to primary care clinics, surgical clinics, and outpatient services clinics, as well as psychology clinics. There we go. And again, to reiterate this, OSHPD 3 requirements only apply to clinics that are licensed through CDPH under Section 1200 or 1250. And so as part of the code application notice, there is a handy flow chart that will help you determine whether or not your project will fall under OSHPD 3. And we're going to have Scott cover the flow chart in more detail. The main first question that we start with when looking at this flow chart is, as I mentioned, whether or not the clinic will be licensed by the Department of Public Health. So whether it falls under Section 1200 or Section 1250 of the Health and Safety Code. And your answer to that will be the first step in following that flow chart. So I'll hand it over to Scott to review that for you in more detail.
Great, thank you, Elle. Let's see if I think you might need to pass the control over to me.
Scott, this is Caesar. I'll go ahead and switch the control over to you. So you should see something on your screen. Yep.
I'm not the presenter though. I just needed mouse control.
All right. Let's see here. Richard, I'm going to go ahead and make sure that you share your screen. Perfect. And Richard, would you mind giving Scott the control, keyboard and mouse?
You should be getting it, Scott.
And there we go. Thank you very much. Sorry about that, guys. All right. So because it was probably a frequently asked question, when does OSHPD 3 code requirements apply? OSHPD put together a CAN, and just to sort of reinforce, the CAN code application notices that OSHPD puts together are a great resource to sort of delve into exactly what applies or what the intent of a particular code was or how OSHPD is reading it. So in this particular case, CAN 1-7-2100 applies to OSHPD 3 facilities and has this helpful flow chart, which we'll go into a little bit more detail. Interesting. Oh, but let's try this. Trying to get to the next slide. There we go. All right.
Oops.
Oh.
Oops. Let me bring that back up.
So while that's coming up, this is a recurring theme with regard to the first and most important question being asked in all these projects. Is the project intended to be licensed by CDPH? And it's a fundamental yes or no. And if the answer is no, as is shown by the top, the highlighted red chart, technically the OSHPD 3 requirements don't apply. So in that instance, there's what's being termed a doctor's office, which is any sort of medical facility that's being operated under the physician's medical license. As you can see, it is reviewed by the local jurisdiction. It is not required to meet OSHPD 3 requirements. Reviewed, approved, inspected by the local jurisdiction. The category below it is ASC, which is Ambulatory Surgery Center. There we go. An ambulatory surgery center doesn't necessarily have to be licensed by CDPH. And in this particular case, if it's certified for Medicare, it's still reviewed by the local jurisdiction, permitted, approved, not required to meet OSHPA 3 requirements. But ultimately, CDPH conducts a survey. And the important thing to note is that just because you're not required to meet OSHPA 3 does not necessarily mean that you don't need to meet other NFPA requirements, which is particularly important in an ambulatory surgery center. So if you're not required to meet OSHPA 3, that was that first branch up at the top. But if you are licensed by CDPH, there are two major branches in the flow chart. We'll go with the one on the left first, which is associated with if you're licensed under a hospital license. So this could be an ancillary facility on a medical campus. It could be just anyone whose primary license is through a hospital, but it's an outpatient facility. So on the far left-hand side in blue, if you are under this category and you are located in a hospital building, then ultimately OSHPAD reviews and approves that project. It gets submitted to OSHPAD, and it goes through a similar process as an OSHPAD 1, but obviously relevant to the appropriate code sections. If you are in a freestanding building, so that is a building that's not currently under necessarily under OSHPAD's review, then the owner is given a choice with how they review, what process they go under, and we'll start off with the one that goes to OSHPAD. If the owner elects to have it reviewed by OSHPAD, it gets permitted and inspected through that process and not the local jurisdiction. But important thing to consider and note is item 8. It will remain under OSHPAD jurisdiction until the owner notifies them. So from a perceived ease of permitting, often owners will elect to go with a local jurisdiction as opposed to going through the state for their review. The next section, again, is if you have the local jurisdiction, provide the certification for it. And it's a question because not all local jurisdictions will certify OSHPA 3 projects. Most of the jurisdictions I've dealt with have, but it's not a guaranteed process. And in this particular case, the flow chart tells us that if they are willing or thank you. If they are willing to review it, then they will review and certify, inspect according to the OSHPA 3 requirements. Handled in the local jurisdiction, that project never goes to OSHPAD's, never reaches OSHPAD's hands. They never do a review. If the local jurisdiction does not, then OSHPAD will review it for a few of the categories, typically architecture, mechanical, electrical. Disciplines will be reviewed by OSHPAD, with the remainder being reviewed by the local jurisdiction. So a split review, and the local jurisdiction is still issuing that permit. The last general category on the flow chart is if you are a facility that is not licensed under a hospital license. So you are licensed through CDPH, you're not associated with a hospital. This would be your primary care clinics, dialysis center, a surgery clinic, that sort of thing. So let's begin with essentially the primary care clinic. So you're licensed. You're not licensed under the hospital. You go all the way to the right-hand side on the flow chart, and essentially what it's telling us is that you're reviewed by the local jurisdiction, but you're required to meet all of the OSHPAD 3 requirements. On occasion, a local jurisdiction can refuse or say they're not qualified to review it, in which case it can't, the OSHPAD 3 portion can be reviewed by the state, but again, that's probably more rare than it is common. There are many third-party plan checkers that will review and are familiar with OSHPAD 3 requirements. So primary care health center has to meet, licensed through CDPH, has to meet OSHPAD 3 requirements, and gets to be reviewed by the local jurisdiction. So the next category is licensed specialty clinics, of which they break it into two different ones. Specialty clinic can be a chronic dialysis or surgery clinic, or a rehabilitation or alternative birthing center. The rehab or alternative birthing center, again, reviewed by the local jurisdiction, has to meet OSHPAD 3 requirements, similar to a primary care health center. If you're a surgical or dialysis center, a choice is being given again. Do you review by the local jurisdiction, or do you be reviewed by OSHPAD? There's a certification required, which is the reason why you proactively have a conversation with the local jurisdiction. Will they certify the project? If it goes to OSHPAD, they do the plan review for everything, and issue it, and ultimately the local ends up doing the inspection and technically issuing the permit through their local jurisdiction and the ultimate approval. If the local jurisdiction does it and is not willing to certify, you've got a choice again, right? Because they need to be willing to certify that the project meets OSHPAD 3 requirements. There we go. All right. If the local jurisdiction is willing to certify, great. They do the plan review, they do the inspection, they do the certification. Perfect. The only thing left is that CDPH conducts a survey at the end of the project. If they're not willing to certify the project, then it needs to go to OSHPAD for them to do the review for the OSHPAD components. And again, the balance gets reviewed by the local jurisdiction. So ultimately, there's nuances to the type of health centers that and what their process is. But if you kind of squint at the chart, the primary question at the beginning has to do with license. And if you're confused about it, it's worth stopping at the beginning of the process and really clarifying which path you're headed down. The bulk of these paths often lead to... Yep.
There's a couple questions I thought maybe it'd be a good point to address on the flow chart. The first question here is there any advantage to having OSHPAD review the OSHPAD 3 non-hospital building freestanding clinic as an election? And basically what the advantages would be is it would bring, or disadvantage as you want to look at it, would be it would remain under OSHPD jurisdiction if it's going to be a freestanding clinic. If we do the entire review, which was on the left side of the flow charts. I'm sorry, I'm backing this up for you a little bit. Over here on the left, it can, if it's a freestanding clinic, the building remains under OSHPD jurisdiction. And the other option is more of an occurrence of the locals do not review OSHPD 3, so sometimes it'll come to us. But the locals are actually required to review anything that is primary care, community clinics, et cetera. OSHPD can only help with the chronic dialysis and surgery clinic. That's why you see it over here on the side by itself. The other question is, can we provide an example of a psychology clinic that would require OSHPD 3? Basically, this would all be determined by the licensure. If you want it to be licensed and available for Medicare, then you would probably want an OSHPD 3. Hopefully that'll help clear that up. So I'll look.
Sure. Thank you.
You were sorry.
And
No,
Richard,
no worries.
Richard and Scott, I do want to take the opportunity to remind everybody on this call that you are more than welcome to type in your question into the go-to section on that dashboard, that question section, and we'd be happy to answer the questions just like Richard did. Or you're more than welcome to raise your hand if you want to go ahead and ask, unmute yourself and participate in an open dialogue and ask that question. So thank you, Richard.
Some of the questions we're actually going to wait until the end. I just felt it was appropriate at that point to address some of those as they were specifically relating to the flow chart. Thank you. I'll pass this back to Scott.
Great. Thank you, Richard. So this last slide in the section just provides an example of a surgery. Let's just say surgery center. And for this purpose, the surgery center has the exact same functionality, sees the same patients, performs the same procedures, but based on the flow chart, it would get reviewed differently depending upon where it is and how it's licensed. So in the first example, the outpatient surgery center is part or in a hospital building, an OSHPD 1 hospital building, in which case it needs to conform and comply with all of OSHPD 1's requirements. Those code sections gets reviewed by OSHPD, the whole works. That same functionality licensed through the hospital, but in a freestanding building, needs to meet the OSHPD 3 requirements. Gets reviewed by the local jurisdiction, if so elected. And in the third example, an outpatient surgery center that's a specialty clinic licensed with CDPH gets reviewed to OSHPD 3 requirements by the local jurisdiction. So even if it's the exact same functionality, how is it licensed, where is it located, are important factors in ultimately determining the set of code requirements that apply and the jurisdictional review that may occur. And I think with that, I will turn the next section over to Richard.
Actually, it goes to Elle. I'm going to see if I can pass control to her.
Thank you, Scott and Richard. So now that we've gone over what OSHPD 3 is, who it applies to, we're going to go into when it applies and when you should look at OSHPD 3. And the answer, if I can get it to change, is right now. So you should get familiar with OSHPD 3 requirements and CDPH licensing requirements as early on in your project as possible. You definitely want to look at these before and familiarize yourself before you start shopping for a space. And so like I said, familiarize yourself with the OSHPD 3 requirements and the licensing requirements under CDPH, and you can reach out to either department for guidance. They also have a lot of information available on their website. Okay, so as I mentioned, you should definitely be looking at OSHPD 3 requirements as you're looking for a space. So, this is an important piece that you survey the proposed space before signing a lease or making a purchase. There are certain things that you want to take a look at, such as which upgrades will be required to make that space compliant with OSHPD 3. I'm trying to get the animations to go. What about the space is currently compliant? I'm going to try and get all the lists to come up. So it's important to, like I said, you're going to be assessing which upgrades are required, which parts of the space are currently compliant, and you're going to be, some of the things that come up a lot are the exam room sizes and the number of toilets in the space. And as far as the plant utilities, some of the key items are the HVAC, especially in the waiting room. And, oh, I went too far. All right, I'm having a little bit of trouble getting the slides to advance. There we go. Okay, so as you're taking a look at these requirements early on, it's important to ask questions. Asking questions about whether or not the space is compliant, working with your consultant to ensure that the space makes sense for the services that are going to be provided. And when you're working with a consultant or with your local building authority, being able to answer the questions. If you're asked whether your facility will meet OSHPD 3 and you don't know the answer, pause there. Do not move forward until you know the answer to that question. And if you do have trouble answering that question, as I mentioned, OSHPD is a great resource, and you can reach out for clarification. That's something that you definitely want to have clarity on before you move forward with purchasing a space or starting construction.
Yeah, I get a lot of questions. This is Richard. I get a lot of questions after the fact. They go to the building department. They're asked, "Do you want OSHPD 3 certification?" And they're not familiar with it, so they just say, "Will it slow the process down?" And it does take a little bit longer because some additional review required. And if they say no, just move forward, they build it and now they can't get it licensed. So then they're calling and say, okay, how can we backtrack out of this? And sometimes there isn't an escape route because it was not built in compliance. So if you don't know, reach out before you answer that question. And like Elle just said, OSHPD is a resource. CPCA is a great resource as well.
Thanks, Richard. Yes, so this is a key point. Is to take a look at these things before making purchases, signing leases, or beginning construction, so that you can prevent any extra delays or obstacles when you're in the middle of your project. So one thing to consider that when you're looking at a space is the option for a plan of modernization. A plan of modernization is described in section 1217 of the Health and Safety Code, and it basically allows a clinic to apply for licensure using a space that maybe meets most of the building requirements, but is missing on a few aspects of the requirements outside of fire and life safety. So it's putting together a plan of modernization, how you're going to bring this space up to OSHPD 3 code so that you can potentially have approval of your license and approval to move forward with this project. And then when you have a space that's almost in compliance, but not quite. So as described here, you would be providing evidence to the department that the building requirements have been met where possible, but that there may be like one or two things or a few things about the building that, like I said, are outside of fire and life safety requirements that you can bring up to code while you have your license active. There we go. So the plan of modernization is a 3-year plan for bringing the site up to code, and failure to complete the plan of modernization as approved within that 3 years can result in a revocation of the license. So it's definitely important that once you've established that plan of modernization, had it approved with the department, that you do follow through so that you can continue operations and maintain your license. There are certain requirements that have to be, or conditions that have to be met in order for a possibility of waiving the building requirements for a primary care clinic. And that would be if for some reason the requirements cannot be met by the applicant, like if it's a cost prohibitive change to the building, and the requirements that have not been met cannot be those that are essential to health and safety of the staff or patients. And it has to be in the interest of public health, basically. So it has to be in the best interest of the public and comply with health and safety requirements in order to be able to have the opportunity to have any of these requirements waived. Okay, so as Richard mentioned, both OSHPD and CPCA are resources for you if you're working on a plan of modernization or just looking at a space that you're considering for a new site. There are examples available of plan of modernizations to help guide you through the process. And you can reach out to regsunit@oshpd.ca.gov for copies of examples of this type of plan. And this is an example of kind of how you would demonstrate in your plan of modernization which pieces of the building do comply with OSHPD 3 and which ones are currently out of compliance that you'd like to address in your plan of modernization. So as you can see here, this is just a table that shows the different requirements in the building code. And for each requirement, it shows whether or not the suite that you're planning to put your clinic in currently complies with that requirement or not. And if not, commenting on how you are going to meet that requirement and your the estimated cost.
And this is a good way to, when you're looking at a building, have this done, and it'll show you exactly what it would cost to bring it into compliance, or at least it'd be pretty close. And you can decide if you want to spend that money to get it there.
Yes, it's definitely a great tool. And just to reiterate, this is something that you want to be doing very early on in your project. This is something that you look at both the plan of modernization and just the building requirements in general. You want to look at OSHPD 3 as early on in your project as possible, and consult with your architect, consult with CPCA, with OSHPD, if you have any questions or concerns before moving forward with securing a space. And with that, I'm going to pass it back over to Richard. Thank you.
Oh, I turn my mic on. Thank you, Al. We're going to go into the how. This is going to kind of, like I said earlier, this is going to be the nuts and bolts, and Scott will be helping me with this as well, but we'll be looking at more of the detail-oriented stuff as we go through. So if you have questions, go ahead and continue to enter them into the question chat, and we'll answer them after this presentation. So there, as you've seen, there's all types of different OSHPD 1, 2, 3, 4, and 5 And again, we're focusing on OSHPAD 3 and OSHPAD 1R today, which is the clinics, is section 1226. There is a lot of pointers to 1224 for hospitals. That's because for a lot of healthcare facilities still have to meet the licensed healthcare facilities still have to meet the requirements of a healthcare facility. And so there are a lot of pointers back to the 1224 requirements for construction. 1226 applies to primary care clinics, specialty clinics, and psychology clinics licensed by the Department of Public Health, and to all licensed outpatient clinical service of a hospital providing in a freestanding building. So typically when I get a phone call on, if a project has to be OSHPAD 3 or not, first question is, how is it licensed? If it falls into one of these categories and you want CMS reimbursement, it's going to be an OSHPAD 3 building. So let's start with that general construction. How this is set up, how the 1226, they talk and generally here are the primary requirements for general construction, as you'll see as we go through these, and then it jumps into different outpatient services of a hospital, where you have radiology, GI, nuke meds, so forth. And then we'll focus on primary care clinics specifically. So we're going to skip over the 1226.5 area today, and as well as the surgical. This is showing kind of how it's broken down as you go through the process. And you see these, and you relate this to the flow chart we looked at earlier. All these items are specifically addressed by their sections in the flow charts. Okay, I just want to make it real clear. OSHPAD cannot, by statute, review primary care clinics, rehab, alternate birthing clinics, or psychology clinics, unless they're under the license of a hospital. So just want to make that clear. We get a lot of jurisdictions that refuse to do their OSHPAD 3 certification. In that case, they would be hiring a third-party consultant for those items, unless they're under the hospital license. So let's start by looking at exam and treatment rooms. Yeah, we're just going to focus at a high level here. Some of the things that you'll be looking at when you're looking at a new space, because some of these things are either cannot be changed or very difficult to change and be more costly. Starting out with the requirement for exam rooms, you have to have a minimum clear floor area of 80 square feet, which is basically an 8 by 10 room. It's basics. The least dimension shall be 8 feet. So that's going to be, again, these are minimums. And I know a lot of the older clinics, you might be at 7'11" or 7'10", and we've actually provided some guidance in the checklist, and we'll cover that later, to allow a little bit of leniency for if you're that close. Because OSHPAD wouldn't, when we're doing a review, if it's an existing clinic space, we wouldn't penalize them if they're that close. So we're trying to provide some guidance to the authorities having jurisdiction. Okay, and the rooms are required to have hand washing fixtures and a counter for writing. And the floor clear area is exclusive of fixed or wall mounted cabinets. So it has to be actual floor space. Just a general note here that a dimension less than 7 feet is not considered a room under the building code. It's actually considered an alcove and is not considered part of the room. And that's where you get into this kind of the 8-foot requirement. But if you have a space that's under 7 feet, it's actually not even considered a habitable room. So just be aware of that if you have these older facilities. Moving to the treatment room, the only requirement here we want to look at is that it is 120 square feet versus 80 square feet, and with minimum of 3 feet required on the sides and at the foot of the bed. Okay, also does require an exam light. There's a few exceptions for that where exam lights are not required, and those will be in the newer code. But does require the hand washing station and a place for medication storage. We get this a lot with clinic spaces. They say we don't distribute drugs, but there needs to be a counter or a cabinet or something that you can lock some type of medication in. We're looking at the types of finishes here on this table. For treatment rooms, it needs to be a smooth and easily cleanable ceiling, and no carpet is allowed. And on exam rooms, you have a little more leniency here. It can be more of a standard type ceiling tile, and carpet can be approved if licensing allows it. So you basically have to put in a request to have carpet put in those spaces. Med gases primarily are focusing on the operating rooms. So we won't spend a lot of time here, but those requirements, a general operating room, be it outpatient or inpatient, has the same requirement here. This is specifically for 1226, and it points you to the 1224 table. So like I said, either operating room would have the same requirement. Nurse call, this is one we get a lot of questions on. Primarily nurse call, if you look at the requirements here, these are for procedure rooms, operating rooms, and so forth. A primary care clinic, if you even look under 1226 here, these are the requirements for 1226, nurse station, operating room, delivery room, etc. But patient toilet is down here. There's a misconception that every patient toilet in a primary care clinic, just because it's under 1226, requires a patient toilet room. We're adding some clarification to that in the next code cycle. Not that it's not in the code, but I know the electrical points you to this table, so it's confusing. So we are clarifying that for primary care clinics, a nurse call only in the patient toilet room is not required. And I'll show you some more information to get you there that's already in the current code in case it comes up. So under 1226 for corridors, outpatient services are only required to have the 5-foot general width and 44 inches if it's exam rooms only. But if there is any type of gurney traffic, surgical endoscopy where they're putting patients on gurneys and wheeling them, you must still maintain the 8-foot corridors. The other item we wanted to point out here was the contiguous functions. So if you have a clinic, all the requirements for that clinic must be in the same department. It can't have a separate treatment room outside of the area, and we'll look at a picture here in a second, a plan here to show you an example of that. But there are some exceptions to that. I'm going to cover those first. And then first of all is if you have a reception area, waiting area, and staff support areas, they can be located outside of the clinic space proper. That is it's in the code that is an exception. And if toilets and drinking fountains serving the public are provided as part of the overall building, they are not required to also be repeated within the clinic space. And shared services such as storage, laundry, waste management can be shared with other tenants within the building. So let's look at a quick plan of it. So the area in red and the lighter red is your clinic space. The lobby is public space to the entire building, and you have another tenant in this building. So you are required to have at least two public restrooms in a clinic. And again, there are exceptions to that, but as a general rule, your requirement is going to be a male and female toilet labeled as all gender. But if those already exist in the building and they're available to all the tenants, there's no additional requirement that is acceptable. Now, if they don't, you may have to provide them in your waiting room for your clinic space. But if they are out there, take advantage of it and use that. It'll save you a lot of space. But one of the areas we're looking at for the contiguous, if you had an office or an exam room that was part of your clinic space, it cannot be separated through a public space. And in this case, it's a very simple example, but if, this would have to be moved into the clinic space proper. Okay, doors and windows. Basically, this section specifically addresses doors that have to be outward swinging for patients. It's similar to a hospital requirement. This is one that's missed a lot. It can be done in a lot of cases by adapting the hardware of the door frame, but it is a cost, something to be aware of. But you also want to look at the swing of the doors, make sure it's not blocking anything if it does have to be reversed to swing outward. And pocket doors are not permitted, other than in administrative and business areas. Garbage, soil waste, and medical waste storage are another area that's missed a lot in the clinics. This is an area, waste collection, that's either is outside of the building, an area to pick up. Again, hospitals have loading docks and balers and everything. A lot of the clinics do not have that, so they do have to provide an area that waste can be collected and set up. And this needs to be an enclosure or a lockable room of at least 25 square feet, and it has to be cleanable. Now, as an alternate to that, you can provide a waste holding room in the building where you just store waste products until they can be picked up. They'll be bagged. And this is, again, a minimum of 25 square feet, and it must be exhausted, but it can be in the building, and they can store waste in those rooms until they are ready to be disposed of or picked up by a service. Okay, and must be immediately accessible to an exterior door, so they're not trouncing through the clinic space looking for it. So looking at general areas for exam and treatment rooms, we're going to look at location terminology really quick. If it says it's in, it's located. You'll see a lot of this in the definitions coming. If it's in, it's located within the identified area or room. Directly accessible means it's connected to the identified area or room through a doorway or an other opening without going through an intervening room or public space. So basically you're walking from one room directly into another. Adjacent means next to, but not necessarily connected to the identified area or room. Immediately accessible, there's some gray text here. We're kind of clarifying some of the language here, but it's available either in the identified room or directly accessible from the room or located within the same department or area. We're changing the directly accessible because it's basically referencing another section, and we're just making it that's in an area located within the same department or service area or within 200 feet. Readily accessible is located within the same department or service space as the identified area room or shared with an adjacent or directly accessible unit. So if you have 2 units side by side, you can share those if it's required to be readily accessible. So that's the general requirement. So we're going to jump specifically into primary care right now, and I'm going to pass this over to Scott.
Thank you, Richard. All right. So one thing I want to highlight in the code is, although these sections are specific to primary care clinics, the way the code is written, it often references back to the general section that Richard just went through, and in turn, many sections reference back to specifically the OSHPD 1 section. So requirements are similar throughout the different types of facilities, and it really is important to review the section, review the reference section, and determine if it applies for your particular project. So some of the general requirements that refer back to the section that Richard went through by reference are corridors, windows, doors, ceiling heights, interior finishes. The exam room section, this looks really familiar to the general section, and it is, because it's all based on the same language. And to re-emphasize the point that Richard made, an 80 square foot exam room is a small room, and often just based on functionality for accessibility, the rooms will exceed these minimum requirements. But the only thing the size and hand washing fixture, extremely important. If you're taking over an existing facility and a room has the size but no hand washing fixture, based on the California Building Code, it cannot be an exam room. Treatment rooms. Now, there is a bit of a difference between language, between what primary care health centers use, what the code is written. And so a treatment room, often for primary care health centers, is a larger exam room that they would do very minor things for a specific case or a patient that comes in. So it is important to make sure that how you're defining the room is matches what your actual functionality is. In some instances, I've had health centers define their rooms as a procedure room, which from a code perspective is a far more robust definition that has significant mechanical implications and a few other things. So it is important to make sure that how you're defining the space on the plans matches what your actual functional needs are, and that you're not underrepresenting and you're not overrepresenting. See if I can, there we go. Administrative center or nurse station. The requirements for the nurse station are fairly flexible, if you will. They do so in primary care facilities. The nurse station wears many hats, and how you handle that space is important. Let's see here. For the medications station, it's important to note that's a room or area. There are some minimum requirements. Obviously, the most important probably being that it's got visual control of staff, a work counter, a sink, access to a sink, lockable refrigerator, etc. But it's important to note that it can be part of the nurse station. The code that references back to the general area and ultimately other areas in the code allow it to be part of the nurse station. So it doesn't necessarily need to be a dedicated room. But again, I strongly suggest that it matches the functionality of however the facility operates. The self-contained medicine dispensing units far more common in hospitals than they are in primary care clinics, but it is addressed in the code because, eventually they'll probably be more common, and it's an option for folks. Clean utility rooms. So these next two, clean utility rooms and soil utility rooms, aren't always how a facility refers to their own spaces. So what's important to note about the clean utility room is that, it's got a work counter, hand washing fixture, and storage for cleaning and sterile supplies. But if it's part of a different system, you don't necessarily need to have a hand washing fixture in it. And again, it's the purpose is to give flexibility to match how the facility is actually being operated. So the clean utility room can in fact be a sterile and clean storage room without a hand washing fixture. see if I can get to a soils utility. All right, soil workroom. Soil workroom is probably most commonly referred to as an MA lab in a lot of primary care settings. The key high points, if you will, a clinic sink, for those that are not familiar with a clinic sink, a clinical sink is a wide throat sink that is able to receive specimens or soiled bed pans. The code recognizes that primary care clinics don't necessarily have the same need as different facilities, and therefore they allow there to be a toilet fastened with a bedpan flushing mechanism to it. The only thing that's important to note is a lot of those bedpan flushing mechanisms will render the toilet inaccessible because it blocks access to the grab bar.
Yeah, and also I just want to add that a utility sink can also be used in place of the clinical sink or the bed flushing. So we do recognize that bed pans aren't used in all facilities, but a utility sink, which is just a deeper type sink, can be used instead.
And to that end, Richard, so the soiled workroom will most commonly have two sinks, a dirty service sink, utility sink, and a clean hand washing fixture. Just something to note for planning purposes, as well as a few other list of requirements that some of which may or may not apply, i.e. the soiled linen receptacles may not necessarily apply to your facility. All right, so support areas. Toilets, Richard started to cover the toilets, and I believe we'll be talking about that again in a little bit. But those requirements for the toilets are the same for primary care facilities as health centers as other OSHPAD 3 types of facilities. So the second item listed here, the general support services and facilities areas for offsite laundry. I think what's important here is that's not actually a requirement that's specific to the primary care clinic section. It is listed in the general section, and more specifically, that code section says if linen is to be processed off-site, then you need to have X, Y, and Z. So just to reinforce the importance of not just looking at the primary care section, but reviewing the general section, and specifically every area that gives you an exception, an alternate, or a if provided clause to determine whether or not that section applies to you. Public administrative areas, the reception and outpatient waiting rooms, again, ultimately referring back to the same section that's in a hospital for general requirements, access to public toilets, which we talked about, direct access, drinking fountains, and access to a public telephone. So medical records, now admittedly, the notion of medical records within the primary care health centers is a holdover from when medical records were paper, but the code has adopted storage for records. It could be paper or electronic, and really what the intent is that there is a space, acknowledgments, functionality associated with medical records. And it could be a workstation, things of that nature. And it doesn't necessarily translate into requiring a room, dedicated room as it did in the past. Oh, thank you. Support areas, staff toilets. Again, you do need separate accommodations for your staff. And I believe if you've got, and Richard, you may know exactly what the threshold is, but I think it's over 5 employees, you need to have separate sex accommodations.
Yeah, we'll be addressing that later.
Thanks, Richard. As well as a provision for storage of employees' personal effects. And again, the code allows flexibility with how you do that, whether it is in fact built-in lockers or other cabinets or means of allowing them to store personal belongings. Staff lounge is optional, not necessarily required. Garbage and trash rooms. Richard did a great job of covering it, and specifically the nuance and options. I just want to reemphasize, for primary care health centers, a waste holding room is probably, for a lot of them, the most consistent with how they handle medical waste. Whereas a surgical center or something of that nature may have a need for a more robust waste holding room. And so even if the code allows or sets the minimum code standards, requirements, I think if it is your project, be cognizant of how the facility operates and which one best matches. There is a note in the code about sizing it appropriately for the needs of the facility. So even though, the minimum size requirement may be 25 square feet, if you've got, a 25 exam room health center, your real life requirements may be greater than the minimum, and the facility should be designed as such. So dental was added to the primary care section, and there's not a lot of requirements for it, but they are somewhat specific, including setting sizes of the dental chair or operatory. And again, terminology is important. Dental facilities refer to their chairs as operatories, whereas the code defines an operatory in a much more robust manner. So it is important, the naming convention is important, especially when you go through a review with a local jurisdiction. If they may not be familiar with the code, they could get tripped up with that term and inappropriate apply something that's far more elevated. The thing to note here, pediatrics patients, if you see pediatric patients, you need to have at least one enclosed operatory. So from a program requirement, that's something very specific. Imaging, there are references in there about imaging requirements and radiation protection. Those that have done dental facilities know that the radiation associated with most dental x-rays is fairly insignificant, but the main thing to note here is that it still needs to be a consideration, point of consideration, both for staff protection as well as patient. So it's placement, it's organization, there are code requirements, minimum standards that must be met. Oral surgery is a fairly significant cliff for an OSHPAD 3 dental dental facility. The oral surgery section references surgical sections, i.e. sterilization areas that are far more robust than most dental facilities. So I would strongly recommend reviewing the code if that is procedures that you do, so you have full understanding of what the code requirements are for OSHPAD 3.
Yeah, the text is gray there because we are changing the language there for oral surgery. Does not refer to 1226.8 unless there's 5 or more patients simultaneously. It basically would fall under the I-2.1. So under that, you're still okay in a regular dental office.
So what Richard just mentioned there is a requirement that kicks in when you have more than a certain number of folks incapable of self-preservation. And it's associated with life safety and the ability to protect those folks and evacuate them in case of emergency, et cetera. And that risk is greater the more people you have, hence the threshold of 5. But in addition to that, oral surgery, last time I checked, references back to mechanical requirements and or sterilization requirements, which are more than the desktop autoclave in most dental facilities. So definitely worth, if you're considering it or you think it applies to you, pause, review all the code sections to make sure it actually does. Last consultation room, fairly straightforward. Sterilization facilities, that's another section that has a when provided clause. So it is absolutely necessary for dental, but how you provide it is and the extent at which you provide it does determine the code sections that apply. And a laboratory. All those spaces are generally, whether or not you're complying with OSHPAD 3, you'd probably provide most of these spaces regardless. So they're fairly consistent with use, but just provide a little bit more code definition to the specifics. And with that, I think I'll pass it back to Richard.
All right, thank you, Scott. I'll try to go through these last few slides fairly quickly so we can have more Q&A. There's a lot of questions being asked on the question chat, so thank you for that. Go ahead and continue to enter that. And we will also have opportunity for you to unmute and raise your hand during the Q&A. And just kind of a reminder that we do know that the handout for the what, where, and how, or what, when, and how is not downloading or not working when you download it. And go ahead and send an email to regsunit@oshpod.ca.gov. It's in the chat as well if you scroll up, and we will send you one via email. So let's get into the requirements for the toilets. This is constantly coming up as a huge issue. And a lot of this is based not necessarily strictly on OSHPAD requirements, but on California law. It's actually a labor law, and we'll go ahead and get into that. But you have to, the plumbing code does state that the separate toilet facilities shall be provided for the use of patients, staff, personnel, and visitors. So that's looking at a minimum. If you have male, female for each, or 2 all gender for each, we're looking at 5 toilets, 1 patient toilet. Those are all considered unisex, male, female staff, and male, female public. So there is an exception for primary clinics only. If the facility has no more than 3 exam bays or exam rooms, the patient toilet can be used to also serve the waiting room. And that would be a huge savings, but you're basically to have 3 exam rooms, you're a pretty small clinic, but that is some savings if you are that small. So the requirements for outpatient waiting rooms are pretty standard. You must have a area for wheelchairs, access to a public corridor, public toilets, drinking fountain, and a public phone must be readily accessible. The advantage here is that if you have multiple clinic services, one waiting room can serve more than 1 department or service. And again, we just added the readily accessible definition here, since the waiting room, that it's located within the same department or service space or identified area or room, or located in or shared with an adjacent directly accessible unit. So if toilets and drinking fountains serving the public area are provided as part of the overall building feature, which we looked at in the previous plan, where they're out in the main lobby, they do not need to be re-provided within the clinic space. So again, if you're looking at a building that has public facilities, you're better off for your own clinic space, make better use of your own space. So for primary clinics, it does require access to public toilets. And under the California Plumbing Code, a lobby public toilet would require one male, one female. Under local California or under California law, that would be interpreted as 2 all-gender toilets. It does not reduce the number of toilet facilities you have, just the signage on it. And we'll go into that a little bit more as well. There are exceptions for unisex, and those are up to the local jurisdiction to make that call. They are in the code. So that is something that is looked at and allowed, and sometimes it has to do more with accessibility as well. So those would have to be looked at on a case-by-case basis. So under the, back to the California Building Code for patient toilets, like I said, these are typically or all unisex, but must have a lavatory in each one, separate from public use, and shall be located to permit access from patient care areas without passing through a public space. There is an exception to that, as I just mentioned earlier. If the primary care clinic is very small with 3 exam rooms or less, the patient toilet may be permitted to serve waiting rooms. Primary care clinic patient rooms, again, must have patient rooms in the primary care clinic care spaces. And if you have imaging services, those also require patient toilets to be directly accessible to the ultrasound procedure room. And it is allowed to share more than 1 procedure rooms. Typically, we see a kind of a Jack and Jill where there's 1 toilet with a flanked on each side with a ultrasound procedure room. Okay, staff toilets, again, requirement here is both male and female at a minimum. It's 1 to 15, and we'll look at some tables for that here in a second. But they must be separate from public and patient facilities. Okay, and again, you're doing the math in your head. This all adds up to about 5 toilets minimum in a standard clinic. Surgical clinics, there must be a staff clothing change area for both male and female. These areas contain lockers, showers, toilets, etc. And they must have a traffic pattern that goes from a dirty space to the clean space and discharge into the surgical area. Going back to the plumbing code, again, we get this question a lot. Staff toilets, male and female, 1 to 15 employees, and this is staff only. You're required to have 1 male and 1 female. If you're over 30 employees, and you need, I believe it's 2 of each. But like a standard clinic kind of falls into this area where we have 1 of each. And again, by California law, they would be considered all gender. And just repeating, because we get this question a lot, it does not reduce the amount of toilet fixtures that you're providing. So if you have 15 staff overall and have 1 all gender, you still need both of them. You still need 2 all genders because you have 1 to 15 female and 1 to 15 male. So there's a requirement of 2 toilets. Okay. In non-industrial office building, we have the same requirement, but there's a footnote, and we apply that as well, that when there are less than 5 employees on a shift, separate toilet rooms are not required, and then you can get away with just 1. Again, it's less than 5 employees. So if you have a small clinic with 4 employees, they're on a typical shift, you can get away with 1 staff toilet. Okay, and this, again, we looked at revising this, working with the Community Clinic Action Committee that Al mentioned earlier. We actually looked at trying to revise this, and we did find that it is in California labor law that does require this, so we were not able to adjust it at all. Speaking of all gender toilets, this is the statute. That's Assembly Bill 1732 that requires these to be labeled as all gender. Signage requirement does not affect the toilet count, as I mentioned. The signage that you're seeing there, the white triangle and the blue circle, is a legitimate unisex symbol as used. The male-female symbology, if you will, on the signage is not required. Just the naming of the room would be all gender or unisex or whatever the facility wants to call it. That's neutral, and that this symbol of is demonstrated. No other requirement for symbology. Okay, just want to hit on accessibility. We're almost finished here. All areas of newly designed or newly constructed buildings and facilities and altered portions of existing buildings shall be accessible. Okay. As a general approach, everything must be accessible unless specifically noted otherwise. When a site, building, or facility, room, or space contains more than one use, each portion shall comply with the applicable requirements of that use. Occupancy groups are no longer used in 11B. Specific accessibility requirements shall be applied to each and every use and each and every room. We get a lot of questions about common use. Basically, that's when you have more than one employee sharing a space. It will need to be considered as accessible. So when you're scoping for accessibility, looking at toilet and bathing facilities, you're looking at toilets for designated groups. If you have a requirement for exclusive use of separate groups, those requirements for the toilet facilities serving each group shall also comply. That would be, example would be if you have a requirement for surgery to have restrooms in addition to typical staff restrooms, both of them would need to apply the accessibility requirements as separate uses. Unisex toilet rooms in medical and long-term facilities for exclusive use of patients not located within patient bedrooms shall contain a lavatory and one water closet. There are a lot of requirements for inpatient toilets, and they do just, this is just stating that they do need the sink to wash your hands as well as the water closet. So when you're looking at hand washing fixtures, just quickly going over the requirements for a hand washing fixture by its nature does require it to be accessible. There's a lot of confusion with the diagrams that are shown here. One is actually a sink and one is a lavatory. The one on the right, I believe, is the lavatory. And so the terminology and the dimensions get a little confusing, but if you use the item on the right for your typical hand washing station, you should be fine. And where we came into problems with the maximum depth underneath, it was limiting the requirement for some of the existing accessible hand washing fixtures to be used. And so we have clarified that those are acceptable, the 17 versus 19 inches. There are a lot of resources on our website. If you go to our codes and regulation page for it's specifically an area for clinics down here, we have the clinic checklist that we attached as a handout today, as well as the clinic flow charts. It's actually CAN 1-7-2100 is the flow chart CAN that'll explain each one of those boxes that Scott went through. And then we also have a checklist. A lot of the local agencies use these checklists for their plan review. It has all the requirements. Again, as Al mentioned down in the plan of modernization, that there's a checklist is very useful in that area to identify all the requirements. All that we ask is that if you don't have it and it's not compliant, don't skip it. Show it as non-compliant. The surgical clinic checklist was just uploaded recently, last month, I believe, and those are available for your use. And we have attached the primary care checklist and the clinic flow chart as handouts to this presentation, and I believe those are successfully being downloaded. Okay. This is just a snapshot of the primary care checklist, kind of explains how to use it. and it goes through every code requirement required for a primary care clinic. Both architectural on the left, mechanical, electrical, and plumbing are on the right. And it goes like for an exam room, here's your requirements. And then it goes to all the requirements. So this is very useful when either plan reviewing a clinic or planning a clinic space. In addition to that, as we mentioned, the CAN that the flowcharts are from is on our website, as well as a newly posted CAN 211B, which is our accessibility CAN. That has a lot of interpretations and a lot of explanations on different types of accessibility and when it is applied. So with that, we'd like to go to questions. And so I'm going to, first of all, thank Elle and Scott for co-presenting this with me. And secondly, I'm going to turn it over to Caesar to lead up the Q&A. Thank you all.
Great. Thank you, Richard.
If I could just chime in for a moment, I just wanted to reiterate that if you go to our website, cpca.org, you can register for part 2 if you have not already, which is on August 31st at the same time. I believe it's at 10 a.m. And both Scott and Richard will be there, and it'll be a great opportunity. It'll be more of a workshop and a good time to have conversation and ask more specific questions, get some airtime with an architect who has many years of experience working with primary care clinics and specifically community health centers. So thank you. And Caesar, I'll give it back to you.
Great. Thank you, Elle. Thank you, Richard, Elle, and Scott for the great presentation. We do have a slew of questions that were typed into the go-to questions section on that dashboard. I do want to remind everyone that you are more than welcome to raise your hand and ask a question. I did identify one person who had their hand raised, but it looks like they put it down. So we do want to encourage the open mic discussion. It seems to work very well, and we are willing to unmute you if you'd like to unmute yourself. But being that the one person put their hand on, I will go ahead and read off one of the questions, Richard, and I think this question is for you. The initial question is, if the owner requests plan review from local and local request, if the owner requests review from local rejects request, and OSHPD does the plan review, is it required to do the inspection and approval for OSHPD 3 portion of the project? This person had a local jurisdiction, turned that final inspection down, and threatened not to give a final compliance, final approval. How would they handle that?
Basically, if you do go to the locals for the review, they have ultimate responsibility for the project. OSHPD may or may not review the OSHPD 3 requirements, but even if they do, it is passed back to the local jurisdiction. They are responsible for doing the inspections during construction to ensure that the project complies with the documents that were approved as OSHPD 3. At the end of the project, they will issue a CDPH Form 270 that basically states that the building was built to the requirements of OSHPD 3 per the approved documents. There are a few minor exceptions to that, where like a primary care clinic, the architect of record can also sign that form. General rule, the local agency should be the first go-to on that as they're doing the inspections. Now, if they're refusing, we get a lot of questions about the locals either refusing to do the reviews, and that's where you would contact Elle or myself, and we would help figure out what was going on. We can't really answer project-specific questions in this forum, but we can answer them generally. So I would say if someone's refusing it, contact us and let us figure out what's going on. And if they're, in this case, they're providing not to do a construction final, again, there's specifics to that, and we can be more than happy to answer specific questions offline for you.
Great, thank you for that, Richard. And do want to remind everyone on this call that you are more than welcome to send an email over to regsunit@oshpod.ca.gov if you have a project-specific question or if you have a project-specific concern. We would be more than happy to take this offline and help you with that as well. So we do have one hand raised. Susan, I want to go ahead and unmute you if you'd like to unmute yourself. We'd like to go ahead and hear from you, Susan.
Yes. Can you hear me?
Yes, if you'd like, if you don't mind speaking up just a bit more so we can hear you clearly.
Okay. Is that better?
That's
Okay.
better. Thank you.
I typed in my question and somehow didn't get the answer, so I wasn't sure it's working on my end. So regarding the minimum areas, floor area, clear area for a room, exam room or procedure room, if I have a counter that's wall mounted and it's entirely open underneath, can you count the floor area underneath that counter as the minimum area required for the room?
If it's just the counter, this is Richard Tannehill. If it's just the counter and there is enough clearance for a wheelchair, you can count a portion of it. It would go back to your reach dimension, your knee clearance requirements can encroach underneath any sink or counter and count as floor area. My best suggestion would be not to use that as your default and to avoid it if you can at all costs, because in theory that counter can someday be replaced with a base cabinet or something, and now you're in trouble. Your room's too small.
Got
I don't know
it.
if Scott wants
Thanks.
to add to that.
Thank you.
Great,
You
thank you.
covered it, Rich.
Perfect. Thank you, Scott, and thank you, Richard, for that. Susan, thank you for unmuting yourself. Again, we want to encourage everyone to unmute yourself, raise your hand, unmute yourself, and we'd be happy to have an open dialogue with you. Gina, we do see you have your hand raised. I'd like to unmute you if you'd like to unmute yourself, Gina. If you'd like to unmute yourself, Gina, that'd be great. We'd like to hear from you. If not, we can move on to the next question. Okay, I'm gonna go ahead and put your hand down. If you'd like to ask a question, please feel free to raise it. Again, the next question comes in way of a typed in question. The question is there a difference if the outpatient surgery may become an emergency center in case of a crisis, such as an earthquake?
Actually, most outpatient facilities are not considered for emergency use, but the answer to the question is no, they would be treated as what the code would require.
Perfect, thank you, Richard, for that. This is a general question regarding that one of the handouts being that the handouts for the checklist section 1226 indicates it's a draft. Please clarify.
We will have to check that. It should not be a draft if it's posted on our website. I have sent out, I might have mistakenly sent out those. If you want the original, it should be downloaded from the OSHPD website. You'll get the correct one. My mistake.
Great, no, that's perfect. We just answering it for the general public. Scott, this is something that you answered in the typed in questions section. So I'm gonna go ahead and read the question if you don't mind. I believe this is a great question and a great answer. So I'm gonna go ahead and read the question, Scott, if you don't mind providing the answer and unmuting yourself. When a surgery center is on the second floor of an MOB and the building is not an OSHPD 3 approved building, what's the process of getting second floor surgery center reviewed by OSHPD 3 use, and would that be considered a freestanding building?
So for the purpose of the flow chart, it would be considered a freestanding building. Even though it's not the only function within that building, it's not part of a hospital building, therefore it's freestanding. Now, with regards to meeting the OSHPD 3 requirements, if it is not currently licensed, the facility would need to meet those requirements, and the recommendation would be to have it reviewed by somebody who knows, could be an architect, based on what the current code is. And then if it's not currently licensed, there may be potential upgrades that would need to be handled through the building permit process. Now, the building permit process will have at the end of it an OSHPAD 3 certification. So ultimately, that's part of the process that you need in form to turn into CDPH to get your license. If the facility is already licensed, any improvements to it would still need to meet current code and be upgraded. Hope that answers the question.
Yeah, it sounds good, Scott. I just want to add that if you're doing multi-tenant type spaces for OSHPAD 3 and you have an existing building that is not OSHPAD 3, it gets a lot more complicated. It's doable, but just something to be aware of. You have to look at the type of, are you sharing the HVAC units, the mechanical system, the plumbing with other tenants? It can get really complicated in that regards because there are specific requirements for those for a OSHPAD 3 clinic space.
For sure.
Great, thank you for that. Richard, I believe this question is for you. The question reads, with the change to HCI, will the terms OSHPAD 1, 1R, 2, 3, 4 be changed?
And 5. No, they as of right now, they're staying as is. Anything that's in statute or building code, we're not going to change right away with the new naming. We actually do not know what FDD, Facilities Development Division, will be renamed to because we are changing from a division to an office. But as of right now, the terminology will remain in the code and may never change, but we'll have to see. It's unknown at this time.
Great, thank you. Bill, we do see you have your hand raised. I'm going to go ahead and unmute you. If you'd like to unmute yourself, Bill, we'd like to hear from you.
Yeah, hey, Richard, how are you?
Hey, Bill.
Hey, question on corridor width. So when we have an OSHPAD 3 clinic that has patients on gurneys, we need an 8-foot corridor. The question is, do you need the 8-foot corridor to extend all the way to the exterior exit? And if we do we need 2 of those, assuming we're required to have 2 exits?
That's a good question. I would, again, I'm going to probably have to get back to you on that, but my guess would you only need to provide the 8-foot corridor where you're actually transferring the patients. And if that area the exit is required for exiting, you probably have to continue it to that point as well. And as far as does that answer your question?
Well, yeah, that's kind of the issue we've wrestled with. Sometimes we have our 8-foot corridor, and then it goes to a part of the building where it skinnies up to maybe 5 feet as it approaches the exit for whatever reason in a previous design of the building. And we're stuck with, well, do we have to widen that up to 8 feet so it goes all the way to the exit 8 feet wide?
Yeah,
and I'm not real clear on this. I see arguments for either side of it.
Yeah, so do I. That's the problem. I can get back to you that way. And what we'll do is the questions that we don't answer here online, we'll go ahead and post for everyone to see. But I'll get back to you on that, Bill.
Okay, great. Thank you.
My take is yes, you're going to need to get them to the exits, but I'd like to confirm that with the fire.
Okay, thank you much.
Great, thank you, Richard. And that kind of reminds me, just want to remind everyone that our presentation will end at 12. So we're going to try to get through as many questions as possible. If we don't get through those questions, we'll go ahead and reply to you and provide you that answer appropriately. So Lisa, I see you have your hand back up. I'd like to go ahead and unmute you if you'd like to unmute yourself, Lisa. Okay, no problem. I'll go.
Hello?
Yes, go ahead, Lisa, we can hear you.
Yeah, hi. I have a question regarding, is there any requirement for a room to wash trash cans and trash bin for OSHPAD 3?
Yes, there is a requirement, but there is a exception an alternate that allows you to provide a storage room. If you store them outside with I believe we went through some slides, that there is a 25 square foot requirement. It has to be concrete. It has to have a hose to wash down carts and stuff. But a lot of clinics that are smaller, as Scott pointed out, typically go to the room within the facility itself as a holding room that can be, bagged things can be picked up.
So the
there's a-
holding room, is it the same room as where we store the medical waste? This is
Yes.
the one you referred that it can be located same floor on the clinic outside, close to the exit door? Is it the
Correct.
same one?
Right. Basically, it's a holding area, so a service comes and picks them up and takes them out.
So this storage holding, you said minimum it's 25 square feet. Is there any plumbing required, like hot water or a hand wash sink or anything?
I don't believe there's a requirement for a hand washing sink. I'd have to look at the requirements.
Okay.
I mean, if it's not identified in there, it's not required.
Okay. Okay, thank you.
You're welcome.
Great, Lisa. Thank you for that, Lisa. I'm going to go ahead and mute you. We do see Mike. We see that you have your hand up. I'm going to go ahead and unmute you if you'd like to unmute yourself, Mike.
Hi, cool. Good morning, everybody. My question, I just want clarification again on the nurse call. Did I hear you say that we don't need to have pull stations in the bathrooms, or did I mishear that?
No, that's correct. If it's primary care only, it does not. And I can actually go back. If you look at the requirements for a primary care clinic, it says it needs to meet the requirements of 1226.4.3 through 0.4.8. I'm guessing on the numbers right now. The requirement for a nurse call in a primary care clinic is actually 0.2. So it doesn't fall into that spread. And that is being clarified. Now, if you have another service that does require a nurse call, if you're doing endo or something, then yes,
Right.
you do need.
Okay, and dental treatment rooms would fall under that additional requirement, right?
I don't believe it requires nurse call for dental treatment.
Okay, I just wanted to make sure because we've built a lot of FQHCs and we've had nurse calls in all over the bathrooms ever since.
It's been enforced that way a lot, and part of the confusion is the electrical code points you to the table. But if you go to the text of it, I'm actually trying to see if I can find it and bring it up for you, but I can come back to that.
Okay, no problem. You don't have to waste your time on it, but if I would like to see that. That's great.
Yeah, if
Thank
you
you
read
so
the
much.
requirements in their primary care clinic where it points you to, it does not include nurse call. It actually specifically skips nurse call in primary care clinics.
Okay,
And if
wonderful.
you have
Thank you.
questions on that, contact me afterwards.
Okay, thank you.
Great. Good question, Mike. Want to thank you for that, and want to thank all of those who have raised their hand to open up the mic and participate in the open mic discussion. I think this is great. I do see a hand raised from a familiar name. Glenn, I'm going to go ahead and unmute you if you'd like to unmute yourself.
Hey, Richard, it's Glenn.
Hey, Glenn.
Great presentation, first off, from all of you. Another thing I found with interest that you commented on, less than 5 for dental surgery. Those provisions really didn't have anything to do with life safety and exiting. They had a lot to do with the procedures that are provided within that dental setting. So you really should look at that, Richard. We have a number of, really they're ASCs in the state that do dental surgery. And that's really why that reference was there after the surgical section. That said, as a clarification of history, you guys really haven't addressed the mechanical requirements in these facilities. And a lot of licensed clinics, assuming dock-in-the-box spaces, really don't look at that aspect of the job. Could you guys highlight that? Because it's always been a problem for people to achieve that level of compliance. Thanks.
Yeah, good point, Glenn. We actually, just going back to the oral, we actually did review that with CDPH on that and got an interpretation, but we will continue to look at that based on what your information you're providing from the historical perspective. I always appreciate that. As far as the mechanical, just so everyone knows, there are very strict ducting requirements for primary care clinics. And we actually have a 6-hour presentation specifically on clinics where we get into the details, electrical, mechanical, but Glenn's correct that mechanical is a huge issue, that they have to have negative pressure in the waiting rooms. It is part of the requirements for public safety. And we will try to highlight that more in any future presentations. But we didn't mention that here, and maybe we didn't highlight it strong enough. But that is a very important aspect of this, that, you know, the mechanical systems, as I mentioned with mixed tenants earlier, the mechanical systems for HVAC has to be ducted in OSHPAD 3 clinics, and that can be a huge issue if you have plenum return on your facilities. So that's something you definitely want to have looked at, and make sure that there's adequate volume and exhaust from these spaces, and an air balance is done and checked. And then that somebody that's knowledgeable of the requirements of OSHPAD 3 does look at your mechanical systems.
And just to tack onto that, thanks, Richard and Glenn. As part of part 2, a subtle plug for that, as part of part 2, HVAC is one of, for all the reasons that Glenn mentioned, is one of the topics that we're going to talk about at a high level, because it does affect every one of the primary care facilities, especially if they're reusing an existing or remodeling or looking at taking over someone else's facility.
Perfect. Thank you, Scott. Thank you, Richard, for that. And thanks, Glenn, for that comment and question. I'm going to go ahead and call on Cheryl. I see you have your hand raised. Cheryl, if you'd like to unmute yourself, we'd like to hear from you.
Hello, can you hear me?
Yes, we can. Go ahead.
Hi, good morning or almost afternoon. I wanted, as we go forward in the world, we're going towards video conferencing in clinic spaces, and I wanted to know what your definition of that room type was and what the area was, since it usually is somewhat a doctor's office, but I wanted to make sure that it wouldn't be considered an exam room that now needs 80 square feet.
No, a lot of the good question, Cheryl. Thank you. No, they basically are doing a lot of there are rooms that are being set up specifically for telemedicine, but under normal circumstances, it's just the physician in his office or the nurse staff in their offices or at a nurse station. Typically, there's HIPAA concerns for privacy, things like that, but they are not considered exam rooms now. If they have physical patients, that's when we go to the patient exam room requirements.
I had one other question. You said no pocket doors, and when you answered, what about sliding glass doors that push out? Say, are those allowed in a clinic space? Clear sliding glass doors that push out in an emergency. Are we allowed to do that?
Just as we would in a hospital setting, they would be allowed. The pocket doors are more of an issue because they're sticking between the walls, and they are allowed in administrative spaces, just not in the clinical spaces. It comes to a lot of issues, accessibility as well as cleanliness.
Right. So I'm just thinking like of an urgent care sort of situation where you want to be able to watch the patient.
Correct. No, those are allowed. Glass doors, sliding glass doors are allowed. We just don't see a lot of those in clinic spaces just because by nature, but yes, there's no prohibition on them. Thank you, Cheryl.
Great, thank you, Cheryl. Great question. We do have another question for you, Richard. This question goes back to clinics. How are we doing renovations / minor alterations in an existing clinic? How shall I proceed to bring it into OSHPAD 3?
If it's not currently OSHPAD 3, you're going to need to bring the whole clinic into OSHPAD 3 requirements, not just a portion of it. That's where you get someone like Scott's firm to do a survey of the space. Now, I saw that question earlier, and I would suggest that you give me a call separately, just because if you don't have an OSHPAD 3 clinic, you can't do a remodel of a specific space and call the rest of it OSHPAD 3, unless it's the clinic in its entirety. And then again, as was mentioned earlier, we're going to be looking at space, we're going to be looking at electrical, looking at mechanical systems, the whole thing. So if you have specifics, please contact me through the regs unit email that's on the screen and we can talk about it. But normally you are going to do an entire building or an entire clinical space within a building and bring that to OSHPAD 3.
All
Now,
right,
if you have
great
an
question.
existing clinic and you want to make it OSHPAD 3, that's very doable as well. And that's where tools like the plan of modernization would come in, or just a survey to see exactly what would be required to convert it. We actually have a lot of clinics that were not intended to be OSHPAD 3, designed to OSHPAD 3 levels, so that in the future, if they do want to convert, it's documented. At least it's a good starting point, but you still have to go through the verification.
All right, thank you for that, Richard. This next question has to do with final inspection or substantial compliance and CDPH licensing. The question reads, at what point do we call CDPH to come out for licensing? Can we schedule the inspection before we get a substantial completion or certificate of occupancy?
It's actually a question for CDPH. I believe they require a certificate of substantial compliance or certificate of occupancy to schedule the site visit. So, but that's a question for them.
Great, yeah, great point. Thank you for that. This next question that's also typed in reads, what's the difference between exam rooms and treatment rooms and quarter width for each?
Scott, do you want to answer that? Or?
So based on the code section for primary care facilities, they define it as an exam room as primarily a diagnostic environment. Treatment room can have minor procedures, and therefore if you're doing some sort of minor procedure, the room size requirements are larger. With respect to corridor width, Richard obviously went through a section that defined the corridor width if you only have exam rooms. And I guess a good clarification, Richard, that if you know, the way that the code's written and it mentions specifically exam rooms as the exemption, is it still exempted if you have treatment rooms?
Yeah, it would be treated the same. The width gets wider at the really when you have the gurney traffic. That's where we're jumping in. That's how I would look at it.
All right, thank you for that.
Thank you
for that answer. We're going to go and skip down a couple of questions. We're running out of time here. We got about 2 minutes before the webinar is over. So I'm going to go ahead go ahead and read this question dealing with accessibility. The question reads, does a mechanical or electrical room need to be accessible? Sometimes we have shipped ladders and electrical panels that could not be completely reachable by a person in a wheelchair. So does that seem to be an exception? However, I have had architects require the accessible rails and ramps.
Okay. Typically, no. Again, those are going to be very specific situations, but typically a mechanical room or electrical room, and it's by itself and in itself as a workstation and would not require accessibility. The component.
All right, Richard, we seem to have lost your.
In it aren't accessible, so no. But again, if you're looking there, you need to look at it as a whole. A lot of the rails and stuff are not typically for accessibility; they're for fall protection, depending on where they are. So it's hard to say with that question, but normally, no, they would not be accessible. There's exceptions for that in the code.
Great, thank you. We have a question regarding Form 270. The question reads, who signs the 270 form? My architect refused to sign it.
Did he do site observation? Scott, you want to address that?
Yeah, it's interesting. The 270 form allows essentially two different entities to sign off on it. One is the architect of record, and one is the building official. And so I would definitely recommend that at the beginning of the project, how that form is going to be signed, whether it's by the building official or the architect, that is discussed in advance, just so that the project knows, the owner knows exactly who's going to sign it, and that person has agreed to do it.
Correct. And I'd like to add on to that, the person that's going to be signing that should be very involved in the construction. If I was an architect, I didn't do the construction or didn't pay attention, I'd probably be hesitant to sign as well. So you want to make sure that your architect or, is involved in the construction process. And that's why a lot of times, like I mentioned earlier, I would default to the building department doing it, or the authority having jurisdiction, just because they're sending inspectors out on a routine basis to inspect different types. They've most likely approved the drawings themselves, but the architect is an option. And if your architect is refusing to sign it, then you have a situation where if the building impact inspector is refusing to sign it, you have an issue. And that is something you have to discuss with them. But as Scott said, that should be agreed on ahead of time.
Great. Thank you, Richard, Scott, and Elle for the great presentation. And want to let everyone know here on the call that we are at time. We have a handful of questions that we did not get around to. So we will go ahead and reply to those questions in an email fashion and provide you that answer to those questions. So without further ado, I want to go and let you know to go ahead and subscribe to our email server by going to our website, oshpd.ca.gov, and subscribing by clicking on the upper right hand corner to get notifications from the Office of Statewide Health Planning and Development regarding a specific topic that you choose on that list of available options. So if you haven't done so, feel free to register it to receive those email notifications, and those notifications can be for presentations, webinars, etc. So if you haven't done so, please feel free to do so. Richard, Scott, Elle, anything else you'd like to add?
Oh, thank you very much. Again, appreciate Elle and Scott's participation in this and co-hosting it with us. And we look forward to the part 2 next week. If either else of you want to say anything.
This is Elle.
Oh,
Thanks all for attending, and hopefully we will see you online next week as well. If not, I hope you all have a great day.
Thank you all.
All right, and with that being said, if you do have a question, send us an email to regsunit@oshpod.ca.gov. And with that being said, it's been a pleasure being with all of you here today, and thank you for doing your part in providing access to safe, quality healthcare environments throughout the state of California. Have a good day.